Welcome to the deep dive. Today, we're going to try something ambitious. We're going to distill the absolute state-of-the-art in cancer immunology and immunotherapy.
And our source is one of those really comprehensive textbooks, the kind you see on the desks of medical students and professionals.
Exactly. So our mission is to pull out the highest yield concepts, the clinical applications, and just give you the practical knowledge fast.
I think it's necessary work. This field has gone from, well, a fringe idea to a pillar of cancer care in a stunningly short time. But you have to remember the history to really get it.
It was not an easy start.
Not at all.
Let's go back to the late 1980s. You have these early, pretty rudimentary treatments like systemic interleukin-2, IL-2 therapy.
Right, for advanced melanoma, renal cell carcinoma.
And it gave us reproducible evidence that the immune system could make these previously incurable tumors regress.
That was the core scientific observation, the proof of concept.
It was. But the clinical reality, it was brutal. The toxicity was severe. I mean, ICU-level care was often needed, and the regressions were sporadic. And that's the distinction the textbook really hammers home, right?
It is. The critics, they confused the poor overall clinical effectiveness of that specific treatment with the profound scientific truth underneath it.
That the immune system had the capacity to act.
Yes. And they were quick to dismiss the whole thing. Some even called it voodoo practice.
So what broke that skepticism? What finally gave it legitimacy?
Precision. The real revolution wasn't just throwing cytokines at a patient. It was the molecular characterization, the identification of the specific antigens that T cells and antibodies actually recognize.
So you could finally point to the target.
You could point to the target. It provided this undeniable mechanistic basis. And immunotherapy only really became standard therapy when new agents, guided by that precision, showed they could significantly improve survival. That's what gets you regulatory licensing.
And that context really sets the stage for why we need this today, because surgery, radiation, chemotherapy, they fail too many patients.
And that's what drives this global health crisis. If you look at the snapshot from the source, it's 2008 data, but it paints a clear picture.
What does that burden look like?
The worldwide incidence was around 180.8 per 100,000. And you see higher incidence in developed countries, Denmark, Ireland, probably linked to westernized lifestyles, pollutants.
But the mortality is often flipped, which is a huge point for health equity.
Exactly. Low-resource countries, even with a lower incidence, often have higher mortality. It highlights these huge disparities in screening, in diagnosis, in access to care.
The numbers on life years lost are just sobering.
In 2008 alone, it was something like 169.3 million healthy life years lost. And most of that came from years of life lost, people just dying prematurely.
So that global statistic, it justifies this relentless search for something better.
It absolutely does. It makes immunotherapy non-negotiable.
So if the conventional methods aren't working, immunotherapy offers this powerful dual approach. What are the two core strategies?
It's all about balance. The way I think of it is, you have to take the brakes off, and then you have to step on the gas.
Okay, taking the brakes off first.
Right. So strategy one is reducing the immunosuppressive milieu, the environment the tumor creates to protect itself.
And then stepping on the gas.
Strategy two, that's boosting the anti-tumor response itself, engineering or activating immune cells. You really have to do both to get a durable result.
Let's start with the brakes then, the immunosuppressive environment. The big breakthrough here has been checkpoint blockade. How does the tumor exploit a natural T-cell process to shut down an attack?
Well, it uses signals that are actually designed to prevent autoimmunity. When T cells get highly activated, they naturally express these molecules, these immune checkpoints.
Like CTLA-4 and PD-1?
The most famous ones, yes. Cytotoxic T lymphocyte-associated antigen 4 and programmed death 1. They're basically molecular safety switches. They tell the T cell, okay, stop, the reaction is over.
And the cancer cell just hijacks that off switch.
It does. It uses it to evade destruction.
So the therapy is, in concept, very simple. Block the off switch.
It's an elegant idea. You use monoclonal antibodies, MABs, to physically block those pathways. Agents like ipilimumab for CTLA-4 or the anti-PD-1 agents, they just get in the way. They release that brake and unleash the T cell.
Now, when we look at the early data for anti-PD-1, the objective response rates were maybe 18% in lung cancer, 28% in melanoma. They don't sound like a miracle cure, but they were revolutionary. Why?
Because these were cancers that were historically deadly, chemo-refractory. Getting any durable responses in a significant minority of those patients where before you had nothing, It was a total game changer.
It proved the biological hypothesis.
Completely. It proved that if you could just free the T cells from that inhibition, they could handle the tumor. It redefined the standard of care.
Okay, so beyond receptors on the cell surface, tumors also use soluble factors, right? Things floating around to suppress the immune system.
Oh, absolutely. They actively pump out inhibitory cytokines, the tumor cells themselves, and also T regulatory cells, or TREGs. They produce these anti-inflammatory molecules.
Things like IL-10 and TGF-beta.
Exactly. Interleukin-10 and transforming growth factor beta.
Hmm.
And these things create this protective bubble around the tumor.
So the strategy there is, again, to block that. Neutralize those suppressors.
Right, and you're seeing investigational agents for this, like anti-TGF-beta antibodies. One is called frisolimumab. Animal models showed that blocking it not only reduced the number of those suppressive TREGs,
But it also increased the good guys.
it increased the number of cytotoxic T lymphocytes, the CTLs. So you get this dual benefit. You remove the cloak and you help the attack.
And we shouldn't forget metabolic pathways like IDO.
Right, indoleamine 2-choline-3 dioxygenase, another sophisticated defense. IDO degrades tryptophan, which is an essential amino acid.
Which T cells need to expand.
Exactly. So if you degrade it locally, they can't proliferate. So blocking IDO removes another one of those barriers.
Okay, so we've taken the brakes off. Now for strategy 2. Actively driving the response. Let's start with monoclonal antibodies.
MABIBs. They're such versatile tools in what we call passive immunotherapy.
And their versatility is really key. It's not just one mechanism of action.
Not at all. They can block signaling pathways the tumor needs, but they can also recruit the host's own immune system through mechanisms like ADCC, antibody-dependent cell-mediated cytotoxicity, and CDC, which is complement-dependent cytotoxicity. And some can just directly induce apoptosis.
So let's use a classic example. The CD20 antigen on B lymphocytes. It's a great target, very stable. The source material talks about 2 crucial classes of anti-CD20 antibodies.
Yes, type I and type 2. This is a key concept for any professional in this field.
So what's the difference?
Type I antibodies, the classic example is rituximab. They are dominant in mediating complement-dependent cytotoxicity, CDC. They're great at kicking off the complement cascade and basically punching holes in the cells.
And type 2, they focus on a different kill mechanism.
Exactly. Type 2 antibodies, like obinutuzumab, are engineered to preferentially drive cell death through direct induction of apoptosis, programmed cell death.
And this isn't just academic. It has real clinical relevance.
Absolutely.
Yeah.
The FDA approval for obinutuzumab in CLL was based on data showing it gave superior progression-free survival compared to rituximab. So this functional difference, it actually dictates clinical choice.
Beyond direct killing, MABs can also be used as, like, delivery vehicles.
Yes, the radioimmunoconjugates. The antibody is like a GPS system that's linked to a radioisotope. It delivers cytotoxic radiation right to the malignant cells.
Maximizing the dose to the tumor and sparing healthy tissue.
That's the goal. A great example is in pancreatic cancer, which is notoriously hard to treat. Using an antibody targeting the MUC1 antigen, it achieved a 16% partial response rate in advanced disease, which is, a real signal in that setting.
Okay, shifting to engineered cells now. CR T cells. Chimeric antigen receptor T cells. This is maybe the most complex and fast-moving area.
It's a phenomenal feat of engineering. A TR is a synthetic construct that you put into a patient's own T cell, and it lets that T cell recognize the tumor antigen without the usual requirement for HLA presentation.
So you're bypassing a major hurdle for T cell recognition.
A huge hurdle, completely.
But how do you build it so the T cell not only sees the target, but actually persists, stays active in the patient long term?
The architecture is everything. The outside part is an antigen-binding domain from an antibody. But the inside, the signaling domains, that's where the magic is. You need the initial activation signal, but the real challenge is T cell exhaustion.
So they just get tired out.
They do. Which is why modern CARs have a co-stimulatory domain, like 41BB. That domain is critical for expansion, but more importantly for long-term persistence. Without persistence, the response just collapses.
And the results in blood cancers have been incredible.
Transformative. CARs targeting CD19 have shown phenomenal, often durable responses in leukemias. Now, solid tumors are a tougher nut to crack.
Because of that immunosuppressive microenvironment we talked about.
Exactly. But we are seeing breakthroughs. There was a phase on trial with GD2-CR T cells in pediatric neuroblastoma. They saw complete responses in 3 of 11 patients with active disease. It's happening.
Okay, finally for this section, let's touch on cancer vaccines. True active immunotherapy.
Right. The goal here is to induce long-lasting immunologic memory.
So this is ideal for preventing recurrence, minimal residual disease.
Yes, the consensus is they work best when the tumor burden is low. The environment is less suppressive, and the immune memory can really take hold.
There's a huge trial in lung cancer with the MAGE-A3 vaccine.
The MAGRIT trial. It was for resected, MAGE-A3 positive patients. And while single antigen vaccines have had some hurdles, the concept is still valid.
And a different approach is the multi-epitope vaccine.
Yes, something like IDM-2101, a 10-epitope vaccine that targets multiple tumor antigens at once. In a phase 2 trial, it got a 60% one-year survival rate. It's a strategy to proactively fight tumor escape by hitting it from multiple angles.
All right, let's quickly connect this theory to a few specific tumor types, starting with acute myeloid leukemia, AML.
Well, in AML, the success of a stem cell transplant allo-HSCT is almost all due to the graft versus leukemia effect, the GVL effect.
Which is basically the donor's immune system.
It's the donor's NK cells and T cells recognizing and killing any leftover leukemia.
And for targeted therapy in AML.
Anti-CD33 antibodies are widely studied. CD33 is on about 90% of AML cells. They show efficacy, but the textbook is clear. Toxicity is a real challenge.
So you have to be careful with dosing.
Very careful. It means fractionated doses carefully combined with chemo. You're always balancing efficacy against toxicity management.
Okay, switching gears. Bladder cancer. A very old school agent is used here.
It's amazing, isn't it? Bacillus calmette-guerin, BCG. It's a standard for non-muscle invasive bladder tumors.
And it doesn't kill the cancer directly.
No, it relies entirely on the host's immune response. The BCG creates this controlled local inflammation in the bladder, which recruits T cells and NK cells to the area to do the job. A classic example of harnessing innate immunity.
And our last example, colorectal cancer, shows how inflammation can be a double-edged sword.
It really does. Chronic inflammation is a huge driver of CRC. A major culprit is the overexpression of cyclooxygenase 2, COX2.
Which stimulates prostaglandin E2.
Right, PGE2. And PGE2 is bad news. It suppresses the anti-tumor response, and it also stimulates angiogenesis, new blood vessel growth, to feed the tumor.
So targeting that inflammation is a prevention strategy.
A key one. NSAIs, selective COX2 inhibitors. And interestingly, even drugs like statins, which have anti-inflammatory effects and can sometimes boost NK cell activity, just shows how interwoven everything is.
This has been an incredibly deep dive. So what's the fundamental takeaway for everyone listening?
The synthesis is that immunotherapy offers this global benefit, from prophylactic vaccines like HPV for cervical cancer all the way to these dramatic therapies. But, and this is a big but, the lesson from those early IL-2 days has to be front and center.
Judicious use is paramount.
Exactly.
You mean balancing the power with the risk?
Precisely. We know low doses of some things can be immunostimulatory, but if you push too high, you can flip a switch and cause immunosuppression or just severe toxicity.
Yeah.
Scheduling, dosing, it's all essential.
Which brings us to the core challenge for the next generation. The immune system is always watching, but tumors are not passive.
That's the final boss,
Right.
really. Tumor cells actively deploy these complex escape mechanisms. They release suppressive cytokines. They downregulate MHC so T cells can't see them.
So the challenge isn't just how do we turn the immune system on.
No, we have drugs for that now. The challenge for you entering this field is understanding and reversing the tumor's multi-layered escape plan. That's how you get durable, curative responses. That's the frontier.
To help reinforce these concepts, here is our self-assessment question for today. It's focused on hematologic malignancy. What two distinct effector functions are mediated by monoclonal antibodies targeting the CD20 antigen, and what are the corresponding antibody types typically associated with each function?
So think about that difference between complement lysis and programmed cell death and the two classes of anti-CD20 agents we discussed.
Until next time, keep digging into the details.